So what's happening? Anybody got a question or story you want to start with?
I have a question. I think that I am not the best at maybe I think that I'm just new to actually treating with Stimpod because I went for a while without treating. But I think what might be happening is there were some of the times where I was trying to hold it for the person, and I now realize that you can't find the sweet spot as well, like Huron was saying, but you have to find it yourself. I mean, we can direct them around where it is, but for them to stay on the spot, and so educating them, I understand that part. But I guess what I want to know is how aggressive do you, I mean, I guess the question is the tapping versus like feeling enough sensation, because I feel like maybe I'm not turning it up high enough for it to have as good of an effect as it should. Um, I think that's
So
the
basic,
problem. Yeah.
just so you have to just be really clear and say this is a tap. Like the
Uh-huh.
first time they feel it, and then you put it on nerve, and they're jumping, like this is a tap, right? And then I'm going to show you what a pinch is, but then we're going to drop it back down to a tap. That's exactly what I say every time to them because no, that's just a tap. That is not a pinch. So you got to go high enough to
Yeah, so I
get.
think I haven't been going high enough, or maybe sometimes I'm not on the nerve, like right on the sweet spot of the nerve enough. Um, so because a lot of times I'm not getting the full motor response if it's one that you should be getting a motor response. Um, so
Yeah, so move it around and just be firm and clear. Like like just be firm and clear. That's all I could say.
Yeah, and the other thing to really keep in mind, every patient is different. Each nerve on that patient can be different. Same patient, same nerve, different day can be different. Patients are coming to you because of pain and discomfort. We are not trying to inflict any additional pain or discomfort, but for the 5 minutes that you're treating that nerve, you want to give them the maximum amount of stim pod energy you can without it hurting, which is why it's a combination of finding the right spot and then you just keep cranking it higher and higher and higher until it reaches the point where it's now a little uncomfortable. And call that a pinch, call that uncomfortable. Great. If you hit that point, let's say it's 27 and now it's pinching or it's uncomfortable. Great, we've gone a little too far. Turn it down to 24 or 25 and verify, is that okay now? If it is, great. You found the maximum amount that they can tolerate, but also thinking again that the probe is a metal detector and you're on the beach. You want to be directly on that pot of gold. If you're close to it, well, you know what? If you dig the hole there, you're not going to find it. And sometimes a millimeter or two, one way or the other, is the difference. And most of these nerves are always running laterally down the leg or down the arm. So the way you're going to find it is not hunting around. It's just draw that imaginary straight line and just laterally go, like if you're looking for the posterior tib at the ankle, somewhere between the medial malleolus and the Achilles is where you'll find it. So going up and down this way isn't going to help you find it. Going this way really slowly, it's somewhere in there. And if it is a motor nerve, yes, when you're on it, we're looking for the maximum amount of motor response with the maximum amount of energy they can tolerate without it hurting.
And also, Kim, is take into consideration the more messed up you view the patient. Like if you see their derangement is pretty severe or they're elderly, you're gonna go have to be higher automatically. So like when I did my own treatment on my own shoulder, I was at like zero point 0.2 and 30 immediately post surgically. But then I dropped it way, way down because like I had a ton of derangement going on and it changed over time.
okay. So I think I'm being too conservative. And I think some of my therapists were being too conservative. So that's probably the problem.
All right.
Yeah. So then do you also turn it up as they're doing the treatment? Do you ask them, are you accommodating to that so that you
No,
can turn it up?
it's more likely the inverse. Like
Okay.
more likely, like I started a new patient the other day, and we were doing the shoulder and the brachial plexus, and she was pretty high to start. Like, but she's a young woman. She was at like 27 or 28, and I left, and I came back, and she's like this is really, really, really strong, and I dropped it down to like 15. So like the nerve recognized what was happening, and then it's awake now, and you have to drop it down.
So you teach them how to adjust the dial when you leave
No,
the.
no,
Oh,
I just check on them.
okay.
Yeah, if they're taking it home, if it's one of those patients, then yeah, you want them to really understand the theory of it. And yeah, just like on an old iPod, you're just going to slowly spin your finger. And when you go clockwise, you'll see the MAs go higher, and counterclockwise, the MAs go lower. And if they're taking a unit home, you're going to take a Sharpie and you're going to literally when you find those nerve locations for them, just draw a circle, with the Sharpie or with a henna pen. And that way, when they get home, they remember, oh yeah, this is where I had it.
And then you tell them that it might be a little bit different because you said it can be different on different days. So they might have to fiddle around with moving it a little slightly from that spot. Yeah. Okay.
Yep. Hey, Jeremiah. So he's back from Alaska.
Hello. Sorry I was late. I had connection issues. It was
That's
not fun. Had three different devices and finally made it on.
Nice.
good. So who else has a question or a story you want to tell?
I do.
Okay.
Yeah, I had a lady come in, shoulder pain, 3 week history of shoulder pain. Not a lot. I tried it at her wrist, like ulnar median. She could hardly tolerate like a two. Two was the most she could tolerate at the wrist. Brachial plexus, same thing, a two. I went out to biceps tendon where she was complaining of most of her pain. She could tolerate a five. Before the treatment, she was lifting her arm up to about 90 degrees and had difficulty closing her hand. She felt really, really tight. Afterwards, she did phenomenal, had full range of motion, better gripping. She could sign her name without pain. Called us back after the treatment. After she drove home, she said driving her pain was 70% reduced, felt a lot better, which was fantastic. Except she left a message that night that she was in excruciating pain. And I haven't seen her since. She's supposed to come back on Friday. I left her a message, haven't heard back from her. Why would she potentially have had that response? Is there any information? My thought is that she just felt good and she started doing a bunch of activity that she hadn't been doing. And so that just irritated it. But could there be anything else that you guys can enlighten me with?
I agree with your assessment, and also I would think that she's a little bit of a drama queen.
A
So,
little anxious, yes.
and to be able to tolerate two when you have derangement is just like ridiculous. Like, um,
Yeah.
you understand what I'm saying, and
Yeah. Yeah.
that
Yeah.
would be she's just drama, and everything
Yeah.
is magnified on her. So I wouldn't say that was caused by a stim pod, but I would say that's just she's that type of personality. JJ, what do you think?
I've had that happen similar with some people that have heightened, like somatosensory um, response anywhere in the body, and they'll even have syncope. That's why the vagal stim is good. I had a younger athlete, and until we treated the right side vagal stim, um, would happen no matter what modality I used on her. And since then, it's completely turned a corner. Didn't matter whether we did manual, soft wave, dry needling, even Stimpod, had some issues. So I think some of those people's systems are just so wound up that you may just even though we want to go to the source and treat them, realize if that is the response, um, then support with vagal stim. And if there's no other contraindications, I would see what happens if you treat both sides. I've had good results with that with other people, even if it's been reflex sympathetic dystrophy. So I agree with you, Kieran. It is that you have somebody that has a heightened response, but at the end of the day, um, some of those people, um, due to past trauma, still need that support. So the bigger question is how do we set that up on the front end that hey, we may treat you, you're going to feel great. That way, it's not just the fact that they're overdoing it because we want them to be active, but I would add the vagal stim and just tell them for the next two visits, that's all we're going to do. And we want to see what response that you get. Because if you still have it on that front, then like Kieran has always said before, we know those people probably have just some other support needs. And so that way you don't have to feel like you're going out on a limb and then this person's having responses that may leave you a different review. So I would do the vagal stim, but I would add the right side as well. I only do about 5 minutes.
Okay. I'll do that. Would it I thought about doing the vagal nerve, but I got a little nervous after her sensitivity and she was apprehensive even though her shoulder was moving really well.
Yeah.
So next time I'll just start with vagal nerve, just really low, see what she can do on that.
Yeah.
So, okay. I'll
And the
try
bigger
that.
part of that is obviously the breathing. And I've also had people, if they don't want to do the vagal stim, that have them take their finger, index finger or pinky, and just tap on that same spot. And if they have a fingernail at all and they're getting any type of like sharp or low grade pressure pinching sensation, and they tap, in that area on and off pressure about 15, 20 times and rest a minute, do it again about 3, 4 times. I've had about the same short term response. Obviously, it's not going to be as big, but if you get somebody that's kind of stuck and they aren't sure about the stimuli, that's one way for some of them. They'll start trusting that, oh, this isn't going to hurt me. This is an area that even if I stimulate myself, I get response. And that's also been helpful.
Index finger and pinky finger, you said?
Yep. And then you just go right
Okay.
to that spot and tap.
Yeah. Okay. Okay.
It's just, and
Yeah.
mainly it's just so they can start trusting their body because until that happens, it doesn't matter what modality we use for them, right?
They're very apprehensive. Okay, cool. I'll try that. One more question, if you don't mind. My wife actually just had C6, C7 disc replacement in her neck. On Tuesday, I've been doing the vagal nerve with her to do that. She likes that. She was doing it before. Anything how would you treat it? Would you even treat right upper extremity? She had radiculopathy, numbness in her finger. Since the surgery, she no longer has the burning in her shoulder. She doesn't have that tight band that she was talking about, and her numbness is about 70% reduced in her index finger from the surgery. How would you treat that? Obviously, for anyone.
Julian, you already know the answer to that. So
Brachial plexus and the median nerve.
just put it on them. Whatever's numb, you got
Okay.
it. You know
All
the
right.
answer.
All right.
Just do
Even
it.
if it's fresh post-op, doesn't matter.
No, like
Okay.
ideally,
All right.
like
All right.
ideally, fantastic.
Okay. All
With
right.
those, the more
Sounds
acute,
good.
the better. And if you have issues that there's ever a surgical spot in the area, um, then, make minimal contact, whether that's with sanitizer or for those people, if they're coming in clinic, they make a sterile gel. That way, if you have to have any contact because you don't want a doc or anybody else saying you messed something up, right? So you got to respect that
Sure.
side of it. So you can do whatever you can for prep, alcohol around the area, do whatever with treatment, and then just get as close as you can to get the result that you need. But yeah, truly, the sooner the
You would
better.
treat the incision. You would treat right by the incision.
I would treat. I actually have treated right up next to them if they're post op. Obviously,
Okay.
if they have a bandage or something else on it, but you know, it, if you understand wound care and with what you've got going on, the more
Yeah.
we can
Yeah.
treat through that area to get migration, then why not? Right?
Okay. All right. I will try that for sure. For sure.
Wonderful.
And
Right.
then I had
Well,
one client come in. Oh, sorry.
that's all right.
Nicole can go. Okay. I was gonna say I had one client come in with cerebellar stroke, 51-year-old, just unknown why. left-sided weakness, hand balance deficits, walking with a walker. I treated it, just went with, I guess what Kieran always says, just go. And so I went at the wrist, brachial plexus, peroneal and tibial areas. And he's been doing great. He gets like immediate improvement with motor control, both with gait and upper extremity dexterity. So,
Great.
yeah.
And I would
And
also
the
treat,
Liberty Patch.
And the Liberty Patch. I did get him on the Liberty Patch too.
and I would also treat the unaffected side as well, even if you don't do it as long, just to set it up because it's going to wake up the brain. The other cool thing you can do is record, and we can chat about this after because it may not be appropriate for everybody, but you can actually record if he still has some movement dysfunction on his sound side and then flip the view of the camera and have him watch it when he's doing activation of that other side.
Oh, okay. Yeah, yeah.
Instead of
Mirroring.
having a mirror box, you can have the phone do that
Okay.
for you. And for some of those folks, it's huge. So you can
Oh,
add that in
interesting.
post.
Okay.
Make
Cool.
a video
Thank
of
you.
him. Make a video of that guy because it's like the sooner you get a stroke patient, I mean, it'd be great if we could get stroke patients immediately. The results are amazing and they're super fast.
Yeah, I wish I would have taken a video of day one. He was 2 weeks post stroke when he came in,
So
just
that's
for a
fantastic.
discovery visit. Yeah. Yeah.
And
He's doing great.
are the results staying? They should be staying because he doesn't have
Yeah,
atrophy, right?
they're staying. I just saw him. See, I saw him he came in for a discovery visit. I treated him. He signed up for Planet Care. Um, Another therapist saw him twice. I just saw him yesterday. He's not walking with a walker. He said he reported 65% improvement with upper extremity function and 50% lower. So yeah, he did great. I'll make sure and treat both sides.
Cool.
Oh, right. Nicole.
Hey, so the Bell's palsy case that I've had been treating, I've treated her since last week, once, yeah. And she's had improvement. She can close her eye all the way. She can almost keep her lips closed, but still some air is escaping. So definitely it's getting better. My question, she said that she has experienced every time that I've done the Stimpod. Fortunately, she's not someone who freaks out, but every time I've done it 3 times now. She said that that same day she's had, it feels like the paralysis, she calls it, is worse that day, but then the next day everything's better. So that's what she said, and she said she thought maybe it was just her nerves were trying to get used to it, and she didn't view it as a bad thing, but she asked me about it, and so I wanted to run that by you guys. I just told her sometimes the body does have reactions where it's trying to figure what's going on and then it figures it out and it's better, which I've seen before with other things. So wanted to get your guys' thoughts on that.
Like on Bell's palsy, it's usually the inverse. Like the next day, they'll feel their face start like they're twitching, like they're waking up. It's like twitch, twitch, twitch when things were paralyzed, and that's what I've had heard the most. I haven't heard what you're saying, but everybody's different. Um, so she's happy anyway. So just keep on doing it. But you'll hear that the next day my face was jumping
Okay. Okay.
and
Um,
twitching.
what are
Okay.
you doing for specific intensity and time on each location?
Right. That was the next thing I was going to say. So last time the last so the time before last, I haven't found out yet how she did after this last session. I'm going to call her today, but the time before last, I did 2 minutes and I did it. I started here right in front of the ear, and then I went and I had it at 2 is it 2 hertz, um,
Yeah.
and then I just turned it up to tolerance.
Hmm.
And so we did here, then we did right by the lacrimal duct, and then we did just right here at the bridge of the nose. We did right at the eyebrow. We did on the side of the eye, and we did right at the corner of the cheek,
Good.
and then we did right here on her jaw. Um,
Sure.
So I did all those points, 2 minutes each. I did both sides, 2 minutes each. And then I finished with vagal stem, 10 minutes with deep breathing and meditative stuff. And so then this time, just, I wasn't sure. I was like, it's probably fine, but I want to talk to you guys. So what I did is I did 1 minute at all the spots this last time, instead of two, just to see. I'm going to call her and see what she experienced after doing that. So
Yeah. And the thing is, it may not change at all, but the reason I asked for that is as long as you have a purpose for what you're doing, so then if they get a response, you can ask them, and then half the time. So then you can at least show them and say, this is the normal response that you're experiencing, but that way you don't have to be fearful of what's going on. Because any nerve, if there's paresthesia, goes through cold, burning, aching, numbness, tingling, whatever, right? And so it's everybody gets worried that it's something that's wrong, just like Kieran said, rather than the fact of, this is probably completely normal. But as long as you document it and you have it, so you can let them know and say, hey, next time we'll drop it in half, see where things are at. And it's also just where they're at in the journey from, going from paralysis to waking things up, because it's a common sensation that anybody talks about, even after a stroke or even like phantom limb pain. Anytime you stimulate it, you have the potential you're going to have that sensation for a bit until it normalizes. But that
sounds
way,
good.
so you don't have to be over worried about it. That way, if you're handing this patient off to somebody else, you can trust and say, hey, here's what your settings need to be and why.
Yeah, I like that. That's great. A couple things real quick also. So um, when I treated her, I forgot that you guys had said to put the small ground pad on the medial forehead. So I had it on the opposite side hand while I was treating. So if I was on the left side, then I had the pad. I had a big pad, big rectangular one on the opposite side hand right here. So that's how I did it. And so next time I treat her, I'm going to put it on the medial forehead. And I wanted to verify if I do that. So doing all those points, do I put it on the same side medial forehead? So if I'm doing the right side,
It doesn't really matter.
okay.
Just have less resistance to go through. So really, it won't really matter.
It won't matter. Okay.
And Nicole, I honestly don't do the opposite side. If it's an acute Bell's palsy, I'm probably going to treat him like twice, and I'm just going to do what's involved, and that's it.
She's got chronic though.
So chronic is an issue, and you're going to have to go way higher.
Yeah, like her chronic, the onset was November. The middle of November was when the onset was. So I would consider that chronic.
Yeah, it's definitely chronic. And you're going to have to crank it up really high. So the ground pad on the face is good because it's going to be a lot of therapy at the hand itself, and especially if she's holding the probe with that hand.
Yeah, I was doing it. I was holding it the whole time. So.
All right.
So yeah, but you said put it here then.
Yes.
Yeah.
Okay.
And I would let her hold it and just turn it up.
Okay, let her hold it and turn it up.
Yep.
Okay. Okay. Do you think she'll have more comfort with doing it if she's holding it? Is that why?
No, I've got other things to do.
And the other thing too, they can dial in if there's a spot that's more sensitive as she's feeling better, but it also does give them control that it's harder for somebody to come back and say, hey, you did this to me. You showed them the device and said, hey, you're in full control of this. So there's value in just giving people back control, right, to also help treat themselves and feel better. So there is that component of some of that anxiety that's there, and it just is.
It's also going to be more like a sweet spot for them than you. Like that's it. Like that's the response you're going to get, and then they can hold that.
So when they put it on a spot, like let's say it's here, that's it, aha moment. How do I describe that to them? Because what
so when you're doing that, you're talking about doing trigeminal, and I'm like, I want
facial here, like because for Bell's. Isn't there like a really superficial spot right here?
You're going basically with trigeminal right there. And you're going to, if you're going for that spot, like individually, if you're not going for trigeminal, I wouldn't even mess with this spot.
Really? Okay.
but you can do trigeminal because it's going to go V1, V2, V3. And then I'm going to tell you, I want you to feel this going V1. I want you to feel this going up. I want you to feel this going medially. I want you to feel this going down.
Mm,
And we're going to move it around until we see it and we feel it. And
mm.
they're going to be able to feel it, even if they're not getting the motor response that you're looking for.
Okay. So the front of the ear you wouldn't do at all for facial.
I do not, unless there's really, I'm just looking at the deficit and trying to treat what is not working properly. So if it's the eye, you do the 3 points for the eye. If it's going into the nose, it's at the cheek. And then you're correct in doing the angle of the mandible or along the mandible and then the side of the mouth. That's everything you can do.
Got it. Would it be better with a chronic case to do every other day?
Yeah, I wouldn't say, yeah, every other day would be fine. And just expect to be able to go very high. Like the higher, the better with these people.
You know
Like
what's
even,
interesting? Oh, go ahead. Go ahead.
I'll give you an example. Like, so when I was with this physio Tanea, she had this woman who had she couldn't close her eye, and it was like a surgical procedure, and she could not turn it up at all. And I had my Resimax with her, so I had this woman hold the Resimax. So it's any vibratory device, I don't care what it is, anything that vibrates. So when I did that, she was at like 4 or 5. She couldn't tolerate anything. I got her to like the mid 20s and her eye immediately closed.
Where did you put the Resimax?
I had her just hold it in her hand because
Oh, okay.
I was just distracting her body from what was actually going on and getting her body the ability to actually get to the level that she needed to close her eye. But it immediately closed when we cranked it up. But she was totally resistant until we distracted her brain from what was actually happening.
That's okay. That's great because what I've noticed with this patient is that I can turn it up. It actually it actually goes up really high. She on the uninvolved side, it goes up higher than the other side. Like she taps out. She says it's enough sooner on the left, on the affected side. So, and I'm not getting much of a like muscle contraction on that side. Or I'm starting to get a little bit around the eye now, but not much. And it definitely contracts on the right side.
Yeah,
That'd be
so
good.
you can try it with her with the cheating.
Yeah, I'll try it.
And
Okay.
Tanea's in the house. How you doing?
Tanea's in the house.
Hi. I forgot all. I was like, where am I supposed to be right now? Calendars mean nothing, apparently, around here. Hi, everybody. Sorry, my screen is disgusting. There I am.
We were just talking
How are
about you.
you? I just heard, I was like, was I supposed yeah. And then I was like, oh, he's just telling the story. Okay. Yeah, she's done well, though. She's done well, that lady. Miss
Good.
Creary.
So
That
what
was the
else?
first time
I
I
have a
ever did that.
question about something. If somebody has a higher pain tolerance and they want it to be higher and they feel like they can tolerate it more, is that not a good thing if it's up too high, or is that going to help them faster?
I mean, I've had people who did it incorrectly and it made everything worse.
Okay.
Like I had a doctor who was trying to treat his fiance and didn't have any idea what he was doing and cranked it up and caused her pain. So just it's not a tough guy response, it's just
Okay.
what's good for you. Tell me when it's a pinch. That's it. And then we'll drop it off that.
And then I know that the bigger pad versus the smaller pad, you're going to feel more when it's the smaller pad under the pad, more likely. But what is your reasoning for using one over the other, the bigger versus the smaller?
So it's your covering. So like for neuropathy, it's for both things. The primary things are you're going to treat a lot of nerves at the same time, right? So when we put the ground pad underneath the toes, we're trying to light up all those toes so we can get sensation. And the ground pad on S3 I only did that because I don't know where S3 is exactly. And I was literally just covering my ass just to I'm going to put this thing so big on here that it's going to definitely hit S3 anatomically. Because I don't use a C-arm, I don't use ultrasound, I don't know where I am. So just literally make sure I'm covering everything.
So if you know where you're targeting specifically, then it's better to use the smaller one to be more concentrated there.
I mean, I mean, it doesn't. Yeah, of course. So like you're doing the hand. So say you want to like, I had a guy come in yesterday, said his whole hand was numb. I'm like, all right, great. I stuck the ground pad across his fingers, and his thumb was jumping at the brachial plexus, and everything was jumping. So I was just covering everything rather than breaking it out. But if someone's going to say just one thing, I'm not going to attenuate all those other nerves with the ground pad. So if you know the endpoint and it's one, great. If you're trying to cover a lot, use bigger.
Okay.
Yeah.
Do that in cervical spine all the time. If it's specific at C5, C6, and it, runs all the way down to the thumb, and that's your only issue, then no different. The ground pad goes on the thumb, and that's where you treat.
Okay. Can you use just the bigger one? I mean, do you sometimes use the smaller and the bigger one on the same people for different areas, or do you just, because we started just getting the bigger pad just so that
So
we have.
you can just put the pad, like a bigger pad, on one finger. It's not a problem.
Okay.
You
Okay, so
can literally
getting the
wrap
bigger
it.
pads is better then. Okay.
Like I'll
It's
just
just
wrap it around their finger.
Yeah.
big thing
Okay.
is just ease of use. I mean, that
Okay,
way
so
you
you
aren't
wrap it around the
supplying,
whole finger if it's the bigger pad. Okay.
correct. That way you're
Okay.
not buying 5 different sizes of electrodes that at the end of the day for the ground one, it intensity wise for most, it doesn't really matter. Some of the face stuff could, because you're going to be such a broad area, but that's a different conversation. But 98% of everything you're going to treat, get the rectangle pad and use it.
Okay.
Cool. So what's happening in Bermuda?
I just got back, so I've been in New York for the weekend. Nothing much in Bermuda. I don't think we have anything special. Let me ask Shari. She was supposed to be on this call as well, but I don't think we have any strange patients, or it's probably not the way to say it. Anything great for Stimpod? Everybody could say hi to Shari. I got patients, or that you had questions about? Stan's just asking what's going on over here. I don't think we got anything. Nothing exciting. We just fix them, We're like the boss now. You've taught us all you can tell us. No, but they ask about you guys all the time. The patients are like, the two guys that came down. So we were talking about you yesterday. No, but I think we've got so far nobody that needs any special things, but it's working.
Good. Good. Michelle, how was your workshop?
It was different. Since I, advertised more neuropathy and sciatica, I ended up getting people who came in who said, well, I just have, I don't know, one lady said her hand just cramps every now and then, just sometimes. Another lady said that, I have a little pain sometimes. I got a wide assortment of different things that kind of threw me for a little loop. I just wasn't prepared for that variety, but I've got discovery visits going, working on some people to sign up. I got one to do a Stimpod per visit. I'm like, okay, if you want to do one visit at a time, that's fine. So, yeah, it was okay.
Good. And your voice came back?
Gradually coming back. I tried the vagal nerve. I did a video before and after. It didn't really change.
Unfortunate.
No, but that's okay. With time, it's getting better.
Good. Tony, any questions? Thoughts?
No, I keep thinking, I got on a call a couple weeks ago and you guys were just finishing talking about incontinence, and I really don't know much about how to treat incontinence.
It's easy. Um,
I like
so
easy.
put ground pad at S3. Treat. So you can do this for 3 minutes on the posterior tibial on both ankles and do the femoral nerve in the groin, and that's it.
Oh, okay. All right.
And you're not moving the ground pad. You want them feeling running down the anterior portion of the thigh and going at the posterior tibial, going under the foot to the big toe. That's it.
Okay. Three,
And
3 minutes at each spot.
correct. And crank it up as high as you can.
Okay. All right.
I have a question about the
Appreciate that.
incontinence protocol. My one lady, she has a lot of hardware in her right ankle. Oh, I forgot. Okay, I guess I could have done her posterior knee
Yeah.
if I can't. I forgot we had mentioned that last time. But this today she was like, I'm not really feeling any difference with doing the pelvic for the incontinence, so I'm okay if we don't treat that. It's not her main issue, but like I feel like it was mainly because she couldn't tolerate a whole lot of current into the femoral nerve area into the groin. So I think it was partly that like she's generally quite sensitive to any kind of intensity. So, but I'll I'll offer it to the back of the knee um on both sides as opposed to the groin to see if that might be worth it. I mean, do you think 3 minutes behind the back of each knee, like for the sciatic, would be worth a
Yeah.
test?
Why not?
Okay. Okay. All right. Thanks. And I guess she would probably feel sensation down the back of the calf then
Going down through
instead
her
of,
foot.
yeah. Okay. All right. And I have one lady who's a horseback rider and she's really liking the device, using it at home. Um, and so I said, you could try using it the same day of because she wants to improve her riding, because she can't dorsiflex or and as well as she'd like or plantar flex. So I thought she's been using it for about a week and a half, and I said it'd be interesting to see if there's any difference when you use it the day of, the same day that you go riding, because
Hmm.
she's, so she can get some like immediate motor learning. So she was excited to try that. So.
And Liberty Patch. Has she tried the Liberty Patch as well?
Oh, not yet. I mean, she's very athletic but uh
Got a
she,
lot of horse. We've got a lot of equestrians who, it's funny, I used to get the question of, well, can we put the patch on the horse? And the real answer is you don't need to put the patch on the horse if you can improve the balance and strength of the rider. That in
Mhm.
turn is helping reduce the workload of the horse. But for sure, have her do Liberty Patch as well.
Okay. All right, thanks.
Yep.
Yeah, but
Angie, the other
she does like it. She does like the she caught on really well, so she's doing the perineal and the posterior tibial and vagus at home.
the other
Um
the other feedback I would have is what we're talking about with some of these conditions like the incontinence. If we aren't able to reach close enough to a therapeutic threshold with output that it has to be too low, then we also have to trust we're probably not going to get the result that we want. So it doesn't have to be cranked up crazy high that they can't tolerate it. But if what you were saying with this person, this client, that they couldn't tolerate much output, then we also wouldn't expect much because in an ideal world, we want that sensory and then motor stim and then, the sympathetic on the back end as we stimulate organs. So realistically, that can be an education point to say, well, either we work on trying to get your body to tolerate this more as we see if we can turn it up, or work on some other things sooner or before it, just like you have access to with the other fascial work, and then see can we get this output high enough that we reach a threshold because it also still has to do that. It's working if it's on one, right, when we initially tolerate it, but realistically it needs to be high enough so then you don't have to feel like you're not treating it correctly or getting the result that you want. You're unable to get the result yet because the client's body either isn't ready for it or you just haven't found a way to get them to tolerate it. So it's a bit unrealistic for us to assume that they're going to get that full response if we can't get at
Mhm.
their threshold. So just kind of keep that in the back of your mind instead of wondering if something's not right. It's also then tweak it after a visit or two and say, what can we do to get this so I can try to get the result that we want?
Yeah, I did educate her like we're kind of nowhere near the intensity that it needs to be to make a difference, and she was totally okay with that. She was like, "Okay, then let's just work on the other stuff that we're working on," because
Sure.
and it was okay with her. So, um, so yeah, I mean, I'm treating her. This is the lady you met with the two sisters.
Mm-hmm.
So I'm now treating both sisters, and then the daughter's stepmom, and then the daughter's bro husband. It's kind of fun to be
You created a
treating.
tribe. Yep.
Yeah, it's like the family of but um forgot what my train of thought was. Um but yeah, I'm treating her right foot neuroma, her left foot neuroma, nerve pain, and then um her scapular area. I was testing rhomboid treatment with the fit pad on the fingers, and then and then this time I did pad on the opposite side of the spine, and then local treatment in the
It's
rhomboid
awesome.
area. And then, so I'm just kind of like seeing, and I'm just educating her too. Like, it's like each treatment, it's like we're trying to find and maintain the pen on on a hair. And um, so it's been fun. I think she's been open-minded to like how things vary. Things that were super, super sensitive to touch on her leg are no longer super, super sensitive, and she is just kind of blown away with that. So she finds it all so fascinating. So it's been pretty interesting treating all the different stuff with
It's
her.
awesome.
Um, yeah,
Congrats.
because so yeah, it's been interesting.
Good. All right. Well, you know what? If that's it, we'll see everybody next week.
Thank you.
Thanks,
Bye.
Thank
everybody.
you.
Thanks, guys.
See ya.
Bye.
Bye.